The GACD is a very exciting initiative because it aims to answer big questions about making impact. And some of the things that we strive to do is answer questions like, how do we decrease the systolic blood pressure of a country by 10 milliliters of mercury? Or how do we decrease BMI of a country by 10%? And so we're asking big questions, and what does it take to decrease a whole country's BMI by 10%, or to reduce systolic blood pressure by 10 millimeters of mercury? So those are the kind of questions we're asking. And also we're also now looking at multimorbidity and implementation science that takes into account comorbidity of multiple NCDs together with infectious diseases. So it's a very important alliance, and they have done amazing work under the leadership of Celina and her team. And so I just want to welcome you and thank you for all being here. And I look forward to, I'm a pediatrician and infectious disease doctor, so I always learn a lot from being the chair of the GACD. So thank you very much, Celina.
Thanks, Brenda. Now I'd like to introduce David Chambers, who is the Deputy Director for Implementation Science at the National Cancer Institute of the U.S.'s National Institutes of Health. And David will be our Master of Ceremonies this evening to sort of walk us through the various speakers, but also to share some of his insights on implementation science from his view.
Yeah, I think this is on. So thank you so much for coming at this particular hour, and thank you so much for having me. As the title that I have at the National Cancer Institute indicates, my world is around implementation science and trying to figure out how do we do best with the research evidence and have not just impact on an individual level, but how do we drive population, how do we drive global improvements in health. What I thought I would do, just because I would guess that amongst our audience we may have some different perspectives or different experiences with this term called implementation science, is spend just a couple of minutes giving you an orientation at least to a little bit about what I think about when implementation science comes to mind. And so there you see us, and most of the time I have the honor of just listening and not talking to these wonderful folks here. But before we get to that, just the briefest of orientations to implementation science from my perspective. So just by show of hands, has anybody seen this particular slide before? Okay, so a couple, but most have not. This actually summarizes a study from now 18 years ago that basically asks the question, if the end product of our research is the publication, what is the impact that it's likely going to have on the population that we're trying to benefit? And so what you see through the middle is this typical publication pathway. We complete our research, we submit it for publication, hopefully it's accepted, it's published, it makes its way into different databases where it is considered as part of systematic reviews, developing guidelines, textbooks, and then hopefully gets into implementation. On the left side, what you see are all of the ways that we lose that valuable evidence. Maybe it's a negative trial and it's really hard to get those results published. Or maybe it's a smaller study or it's published in a journal that then doesn't get looked at when it's time to expand and think about what the next set of guidelines should look like. The right side just estimated approximately how long it took. This was as of 2000, but it hasn't changed that much, to get through each and every one of these steps. The tagline, which has become this factoid separate from where it came, is that it takes 17 years to get only about 14% of research to benefit patient care. The point is that if we just rely on our scientific publications, we're not going to do much when we're really talking about driving individual and population health, which is why most of us in the room wake up every morning and try and make a difference. One particular reason why we have a struggle is because we don't always think about the fit between our interventions and the populations that we're trying to reach. There's a famous statement, which I'll paraphrase, a blank needs a blank like a fish needs a bicycle. Too often, our investigators are creating interventions that may, again, be as useful as a bicycle is to a fish if they're really trying to reach the population. And so the point is that we can't lose sight of the importance of fit. And And what's wonderful about this panel is we have the opportunity to hear from multiple perspectives and really get a sense of what does that fit look like in our complex lives, in our complex systems, and in our complex societies. Last thing, when we think about implementation, we're drawing some degree of distinction between asking that question, what does it take to try and improve one person's health at a time? And that's what you'll see the left, the what, that what question. What is the intervention that if this person receives it will have some benefit? And if you look all the way on the right, you see those health outcomes that we're ultimately trying to get to. And so what happens is most of our trials, the usual trial, only focuses on the very left and the very right. It says, what do we do if all of the conditions are in place so that somebody can receive an intervention that may benefit their health? And then all the way on the right, does it drive some health outcome? If we don't go further than that, then what happens is we jump over this hugely important question, and the question that I think the report really tries to emphasize is how do we get these effective interventions, the whats, to be delivered, and what are the outcomes that we need to be thinking about in order for implementation to be judged as successful or not? Is it acceptable to the patient population, to providers, to health systems, to communities? Can it be sustained over time? Is it feasible to be delivered? What are the costs associated with the entire system that might need to change in order to make it more easy to deliver evidence-based care? What is the level of uptake within our systems that we want to try and get so that we're not just helping one person at a time, but that really over time, and again, this is sort of where the core of implementation science comes in, we're figuring out what those implementation strategies are, we're driving those implementation outcomes, which as you'll see have knock-on benefits to our service systems, and then ultimately improve our health of our populations. And so while the core of implementation is asking that how question, what all of us, I think, are still focused on is can we ultimately help people wherever they are? Can we improve their health? Can we improve their health care where they're seeking it? And that, if we do everything well, is what we believe will make the most impact. So that's my quick primer. You'll see the smiling faces again. And so what we'll now do is shift to hearing from a variety of experts on our panel who can talk both from the experience of leading individual projects and from the experience of the challenges of chronic diseases. And it's so incredibly important to recognize that implementation is a multi-level, a multi-stakeholder challenge. And so again, it's really helpful to have such a great experienced panel to be able to listen to now. So first up is Dr. Rajesh Vedanthan, who's the director of the Center for Global Health in the Department of Population Health at New York's School of Medicine. Had a relatively short commute, I think, here today. And Rajesh is going to talk about one of the specific projects that has been funded through GACD.
Great, thank you so much, David, and thank you to the GACD for organizing and for inviting me here today. And it's really a wonderful honor to be on this esteemed panel. It's nice to see many friends in the audience from many years past. I'm going to be giving the perspective of one of the researchers who was participating in the GACD project. Actually, it's very nice to have a co-researcher, although now he's graduated to a much higher level on the panel as well. And just to give a few reflections, I was, until recently actually, at the Icahn School of Medicine at Mount Sinai, and there along with my mentor and previous boss, Vedanthan Fuster, we're involved with the hypertension project in collaboration with our colleagues in Kenya, looking at trying to optimize linkage and retention to care. So in terms of that cascade of care, after finding people who are at risk for disease or at risk for elevated blood pressure, really trying to link them into the care system and maintain their engagement in the care system. But what I wish to talk about today really are just some lessons and thoughts and reflections that we have had overall as a community of researchers. I think one thing is if you look at the history of the GACD and us and the field of implementation research, is that as we grew as implementation researchers, the field of implementation research also grew. And we definitely made a lot of mistakes along the way, and we learned from those mistakes. We're still learning from our mistakes. But I think that part of the process of growing and developing, maturing, and learning from those mistakes has actually contributed, I believe, to the actual field of implementation research, whether it comes to the importance of process evaluation and thinking really carefully about context and who interventions are working for and why, and who interventions are not working for and why not. If it comes down to actual study design and the intricacies of the statistical analytics related to study design, if it comes to how should we actually think about community stakeholders and whether and exactly who those community stakeholders should be, whether it comes to the relationship between us as researchers and policymakers and program planners, all of those things I think evolved over the last maybe 5 to 10 years as a field, and I think definitely evolved for us, and I think at some level I think we can take some claim with respect to contributing to that growth overall, both for ourselves as well as for the field in general. I think the other thing that was very important for us as a program and for us as researchers is that there was a very strong emphasis on early career researchers and on capacity building, and that happening across the world. And I think one of the powers of the GACD was that it wasn't, I'm from the US and my project was funded by the National Institutes of Health, but it was not just a US focused program or project. We had projects that were funded at the time at least from Europe, from the UK, from Australia, subsequently actually increasingly funded by other countries as well, India, China, etc. Over the course of our decade together, we have actually manifested what's called these implementation science workshops. We've actually trained hundreds of people from all over the world. And I think one of the key things that we did at these annual meetings was to ensure that we were targeting those trainings not just for us and our research teams, but really for people interested in implementation research from those host countries. So we had people from China, for example, who are not part of the GACD, who were able to take part in those implementation science workshops. People from Brazil are going to be taking part in the implementation science workshop coming up, and people from Argentina were there last year, for example. And so I think all of those things were very important. If I think about what our results showed as researchers and as research projects, the track record is mixed. Some studies were wildly positive, and everyone's very excited about those, and other studies were neutral or negative, and there's a certain amount of lack of enthusiasm about those, but I think those neutral or negative results are just as equally important in terms of helping to guide not just us as researchers, but also, again, program planners, policymakers, implementers, in terms of having now a toolkit of different things that are able to be chosen from, whether it's down at the micro level in terms of care delivery and who actually is delivering those medications to the individual patient, or if it's done at the sort of very high level policy in terms of implementing let's say, for example, salt reduction policies for the entire country. I think the final thing that I wish to say is just that one of the things I'm very grateful for with respect to the GACD is that it really helps stimulate a network of researchers and friends and collaborators and really folks who are in solidarity with one another, and I think in mutual support of one another. And I think that was actually very important. So I'm able to cheerlead Adolfo, for example, as he does his wonderful things in Argentina, and I'm hoping that folks will be able to mutually cheerlead everyone else as well. I think one final thought, the sort of thing I'm left with this year at least, is that one of my favorite phrases actually comes from, I think, a sort of very ancient philosophy, but it most recently manifested in that movie, The Best Marigold Hotel or something like that. Basically saying, in the end, everything will be okay. And if it's not yet okay, it's not yet the end.
Wonderful, and I think again, one of the really important lessons is that we can learn from each and every experience. That too often in research we're really only focusing on what seemed like the biggest successes. But through implementation science, we've been able to identify a lot of the barriers with the idea that the next time we're trying to improve health, we have a much clearer sense of what we shouldn't be doing as well as what we should be. So I think that's a great point. So now I have the honor to turn to my right to Professor Adolfo Rubinstein, who has been both a past GACD PI, but as was said before, has graduated upward and is now Health Secretary in Argentina.
Thank you, David. So this is like, thanks Celina for inviting me, and this is like to come back to my former life, my previous incarnation. But 2 years ago, I was there, sitting there as a researcher. Less than 2 years ago, actually. So,
So when you become Minister of Knowledge, you forget how to
yeah, I forgot how to use this. Okay.
Yeah.
Okay. So let me just briefly tell you something about my country, Argentina. This is an upper middle income country where you can see the trends in NCD, the age-adjusted incidence of NCDs are decreasing over the last decades, and Argentina almost finished its demographic, epidemiological, and nutritional transition. And you can see that all the decrease is mostly attributable to cardiovascular disease rather than cancer. And if you see a picture of what is, the burden of disease of Argentina in terms of NCDs is mostly 70% or almost 80% of the burden of disease is attributable to CVD, cancer, diabetes, and COPD. And like most of the developed countries, but with a higher prevalence and incidence of premature mortality under 70. This is a problem of developing countries. And if you see, for instance, hypertension, you can see that even though the prevalence is 40% in people over 34 years old, you can see that at the end of the attrition, and at the end of the day, 1 every 5 hypertensives are just 1 out of 5 hypertensives is controlled. So this is a problem. What are we doing in Argentina? Now we are investing in programs to prevent and control NCDs, and we have 2 earmarked prevention programs for NCDs in Argentina now under progress. One is sponsored by the World Bank and funds from the Argentinian Treasury, $500 million, directed to prevention and control of NCDs, basically strengthening of primary care to improve quality of health services, to control NCDs in low-income settings. The second one is development of population-based intervention at a local level, mainly municipalities, to promote adoption of healthy lifestyles. And the third one is implementation of capacities to improve NCD surveillance and information systems. And the other loan and the other national program, this is sponsored by the IDB, Inter-American Development Bank, is mostly focused on integrating networks of health services, of primary care services and hospital services to improve NCD treatment, diagnosis and treatment, and including cancer. And let me just tell you about my personal journey. So this happened less than 2 years ago. So in November 2016, I was there in the late-breaking trial session at the American Heart in New Orleans, where we presented the results of a study that was sponsored by the GACD. Was sponsored actually by NIH, but under the GACD umbrella, was in the first call of the of GACD, and this was an implementation research study led by community health workers, a multi-component strategy to reduce blood pressure in the community setting in low-income population. And you can see that, Vilma Irasola, probably most of you know her, was my partner at my former institution, and Dr. Jian He, and this was just less than 2 years ago. Just 1 year ago, we published this study in JAMA, and at that time I was Secretary of Health, and this is a study that we published in JAMA, and finally, now all the planets align, and a former researcher will turn out to be Minister of Health or Secretary of Health now, and And this was just a personal journey from research to policy making. And now we have implemented a call joining GACD. Argentina has joined GACD to make a call to I mean, this is the announcement on RFA for implementation and dissemination of strategies to improve NCD prevention and control in vulnerable population in Argentina, focus on hypertension and diabetes and tobacco smoking and cardiovascular disease, acute MI and stroke. So this is like a personal journey. Less than 2 years ago, I was a former researcher trying to convince policymakers to implement NCD strategies for prevention and control. And now I'm a policymaker that should implement what I said I would do less than 2 years ago. So this is my story.
And so again, what to me this reinforces is that if we look at a lot of different frameworks, and there have been a lot of them that have tried to map out these processes around dissemination and implementation, you'll see that they are at multiple levels, and the strategies that are needed are at multiple levels, from the individual on to the policy level in much of these cases. And so here you have, from what you just heard, a journey that traverses multiple levels and ideally comes up with a solution that has those features, that the policy indicators, that the system indicators, that the clinician indicators, and that the individual indicators that would show success for implementation are all moving together. So again, because it is a multi-level problem, we want to make sure that at the end of the day, we are providing benefits to people who are living with chronic disease, and that's the ultimate success. And so we are very fortunate to have Roslyn here, who can speak to the challenges and maybe some of her comments about how chronic disease and how ideally implementation science related to chronic disease can truly impact and improve lives. And so the context within which we all live, the context within patients, within families, within communities is so incredibly important. So we're very lucky to have Roslyn talking a little bit from her perspective. So Roslyn, thank you.
Thank you. Good evening. The American gospel duo Mary Mary says in their song, "Can't give up now. I've come too far from where I started from. Nobody told me the road would be easy, and I don't believe he brought me this far to leave me. Indeed, the road I've traveled can be described as anything but easy as a patient with hypertension. I am Roslyn Grimes, a 50-year-old immigrant from Barbados. I've spent most of my life living here in the United States, where I was diagnosed with hypertension in my 40s. This medical condition became the catalyst for several changes in my life. Hypertension, in addition to my autoimmune disease, impacts my body every day, rendering me unable to perform normal activities that even I once took for granted. I can't get up quickly unless I want to be greeted with a rapid rise in my pressure and heart palpitations. Physical pain afflicts me daily, often causing my blood pressure to rise dangerously high. My hypertension led me to developing sleep apnea, and as a result, I am constantly tired. Small amounts of dehydration can bring about terrible headaches, bouts of nausea, and elevated pressure. However, the worst way my high blood pressure has physically affected me occurred when I discovered after an MRI that months previously I had a mini stroke. It was scary to learn that this had happened to me without my knowledge. Hypertension truly is the silent killer. A toll has been taken on my social life, as attending functions and gatherings isn't as easy as it once was. I have to consider which activities might cause a rise in my pressure, and I have to carefully watch my diet. Dinners at wonderful restaurants aren't as exciting when 3/4 of the menu is off limits. In addition to my physical self, my emotional state has been greatly affected. I live with 2 of my 3 children, and frequently I feel as though I am a burden to them with my condition. I've also become depressed because of my physical limitations. I lost interest in the things I used to love doing, while I feel a great sense of loss over activities my body no longer permits me to perform. However, the part of me that has been most transformed due to my hypertension has been my spirituality. I've found myself tested in new ways that has only made my connection to God stronger. My faith is what has kept me grounded throughout this entire journey of adapting to my newfound limitations. I feel blessed to have great doctors and social workers at Mount Sinai Hospital in my life, such as Dr. Sunny, with his genuinely sunny demeanor, and Ms. Lopez, a truly kind individual, both of whom encouraged me to share my story of hypertension with you today. I'm fortunate to have enough friends and caregivers, especially my kids, who have made it clear that they love and care for me and cherish me deeply. With the encouragement of an amazing support system, I am slowly regaining my life, my strength, and my independence. Although my speed isn't quite what it used to be, I can perform tasks now that I was incapable of doing just a year ago. To all the great doctors who are listening to my story today, thank you for caring and giving it your all. I speak on behalf of many patients who would like you to keep exercising patience. It can be difficult to verbalize exactly what we are experiencing physically. However, doctors and patients cannot do the work all by themselves. I believe the government should start listening more closely to us as individuals and not just a collection of people. Give us what we need based on our stories. Medicine needs to be more accessible, with lower costs so working class people can afford it. More arrangements should be made for obtaining medicine for those with limited mobility. Food costs are much too high. Access to fresh food and vegetables depend on where you live, and these resources shouldn't be kept primarily in the upper class neighborhoods. Patients afflicted with hypertension struggle enough with their diet, and options should be even further limited. And options shouldn't be even further limited to primarily canned and other sodium-loaded food. Corporate America has a role to play in this solution as well. Working people should benefit greatly from stress outlets such as yoga and meditation. Anything that would allow workers to unwind and become a little less stressed. A little bit of time to relax can go a long way, physically, mentally, and spiritually. Thank you for listening. I hope that today we can all walk away with a stronger understanding of how hypertension affects the patients who have it, as well as even more compassion in our hearts. Thank you.
Thank you so much for sharing. I think one of the things that too often we get bogged down into is a particular diagnosis or a particular set of symptoms, and the idea that we don't necessarily think about the context of someone's life, and that's both in terms of some challenges but also in terms of the supports. And we don't have to think traditionally medically about there is one particular answer and it is found in this particular clinic. But as we think about the broader set of community resources, the broader set of determinants of health, we can make a lot of progress. And so what's great about, again, the report is that as we look at the different projects that are summarized, they all focus on different aspects of this broader sort of social equation or sort of ecological equation. What is it that we can do to try and meet people where they are and try to provide support, to try and provide benefits? And wonderful to see where those can make a tangible difference. Thanks so much for sharing. Next, we're very privileged to have the Deputy Director General of the WHO, Dr. Soumya Swaminathan, who is both a pediatrician and globally recognized researcher in infectious disease, and who can share her expertise as well with us.
Thank you, David. And it's nice to be among friends, and one feels like a researcher again. I also identify with Dr. Rubinstein being a researcher. You can never be far away, and it's great that you have an opportunity now to translate all that into action. So, I'm a clinical researcher by background, and my first experience of implementation research was when HIV testing for all TB patients was to be made policy. The WHO already recommended that. But in India, there was a lot of hesitation because the TB program managers felt that they were just getting stabilized with the revised control program, and that introducing this HIV testing to all TB patients would create a lot of stigma around TB and would have a massive pushback or setback to the program because the population prevalence of HIV in India is fairly low. So they did not want to go for universal testing. And so we did an implementation research in 2 districts in a population of about 500,000 people where we offered HIV testing to all TB patients who came into those clinics and documented that not only was there a high uptake, but there was no big pushback, there was no stigma, it was a mixed methods research, so there was qualitative and quantitative. And based on the results of the experience, which was a real life experience in those 2 districts done through the program, the National TB program agreed to put that into policy and scaled it up first in 6 states and then across the whole country. So it's a very powerful, it brought home to me from as a person who was doing more clinical trials in the clinic, which of course ends up as a publication and then many years later goes into a systematic review and then finally into a guideline, that if you did the implementation research with and answered the question the policy makers had to begin with, then you're much more likely to have an impact on policy. So the lesson for me was, and which is important for all of us, is that implementation research is always a multidisciplinary team. Ideally, it should have social scientists or economists in addition to the clinical or epidemiological researchers and subject experts, but also the policymaker. And you must answer the question that is relevant for the program. So, for example, you have a lot of guidelines coming out, and that's where I think the WHO, we're also thinking about how do you reduce the time from developing a global guideline to actually having it implemented in multiple countries. And I think in the field of NCDs, this is very critical. Whether you take mental health, there are policies. Many countries now have a mental health policy. They've committed to doing it. But it's very difficult to do, particularly in settings where you don't have psychiatrists and you don't have the professionals. So you have to develop models of addressing mental health problems at the community level in a setting where you don't have too many psychiatrists. And now there's technology that can be used. You can use telemedicine or mobile health applications and so on. And even with very few professionals, you can still have a cadre of health workers trained. But you have to try it out and see if it works in that particular context and in that setting. So that's where implementation research is really brings it alive in a particular context and shows that it can work. And even within a country, you may have different rural versus urban, the same strategies don't work, and high income versus low income communities and so on. So for scaling up NCDs, I mean, financial resources is one thing, the lack of resources, but it's more than that. I think it's the evidence to action gap. It's the know-do gap. And while now we have all the knowledge a lot of the knowledge. What we still lack are the strategies.